Thank you so very much. It is a great honor to be presenting today. I am so sorry, due to health reasons, I cannot be present in the audience, and I cannot be present there. But I am happy and honored to give this presentation. Now, I will be talking about what are called immunonutrients in critical illness. And there are two things that I will be talking about. The first thing is I will concentrate most of my talk on arginine, although I will mention the effects of omega-3 fatty acid also. The second part is that I will focus on human beings, and I am a surgeon. I am a critical care physician also, and I have done a significant amount of research in this area as a physician scientist. So what I will be describing today is what is now called the arginine deficiency syndrome, and when and how we are using arginine supplementation as a replacement therapy. I have some objectives that are quite clear. I will examine the mechanisms of how arginine deficiency is developed, evaluate the physiological consequences of arginine deficiency, that is what happens downstream metabolically, and then we'll look at the benefits, the risks, and maybe some of the contraindications to the incorporation of arginine replacement therapy in clinical practice. Now, I know many of you are not involved in taking care of patients, but I hope some of this is helpful. I currently have no conflicts of interest. I do consult with different industries on a case-by-case basis and with different organizations. I did have a patent on arginine deficiency syndrome and COVID-19. I do not know the current status of that patent. And I was Chief Medical Officer for Nestle Health Science in North America and member of the Board of Directors until 2018. I do not advocate, and clearly I do not in any way at this point tell you how to and what to do with any commercial formula. For that, you will need to go and consult if you are thinking of applying some of these replacement therapies in your practices. So what is a syndrome? Well, a syndrome is really a group of signs and symptoms that occur together and characterize a particular abnormality or condition. And we described arginine deficiency as a syndrome in 2007. And we've identified that arginine as an amino acid became deficient under certain diseases, such as in cancer and after surgery or trauma and in certain infections, and certainly in patients with hemolytic diseases, and proposed that all of these diseases shared a common set of signs and symptoms that could be attributable to the decrease in arginine. Dr. Sidney Morris, my mentor, also talked about arginine deficiency a few years later in a landmark paper that I would urge you to talk about, to read at some point. So what we find is that there is a mechanism of how arginine deficiency is developed. There are physiologic impairments downstream from the lack of arginine as a substrate for particular metabolic processes, and this lead to a clinical manifestation of disease. And the hypothesis that we're going to test today, and that I hope can be successfully demonstrated, is that by restoring arginine as a substrate, we can restore physiology and correct the physiologic impairments that we see in patients, and therefore improve clinical outcomes. Now, let's talk a little bit about arginine in different species. And I am certainly not an expert outside of human beings, but I want to make sure that we all understand that arginine metabolism is central to evolution of different species, and that different species have resolved and utilized arginine metabolism in very different ways. And so it is really important that we do not apply what we see in humans and think that it can be extrapolated into other animal models. In general, in mice and rats and humans, there are significant differences between the species. But in general, arginine is what is called a conditionally essential amino acid, and I will be talking and diving deeper into that, and I may end up sounding a little bit repetitive in some of these ideas. In these species, arginine is central to what is called the urea cycle, which in and of itself is the mechanism, the principal mechanism of how these species get rid of excess ammonia and excess nitrogen. In dogs and cats, arginine is actually an essential amino acid, and if you feed or these animals do not take adequate arginine, they rapidly will develop severe metabolic abnormalities and may even die within a day to 3 days or so. So in dogs and cats, and in general in species that are mostly carnivorous, arginine is an essential amino acid. In birds, it's also essential. But birds, even though every species does have the capacity to have a urea cycle and all have the enzymes to produce urea, in birds, the principal mechanism of detoxification of nitrogen is uric acid, and in fish, ammonia is actually diffused through the gills. Arginine supplementation is used in veterinary medicine to improve and increase growth for chicken, fish, and other species. So let's dive a little bit deeper. Arginine, again, in a normal human being is not essential. Normally, we are able to generate arginine from citrulline through a two-step metabolic process. Arginine also comes to us through a significant amount of protein turnover, and comes to us in the diet. In the diet, citrulline can be taken, and the only real source rich of citrulline is, interesting, the watermelon. But glutamine also is, as part of protein, is another source, and it's converted to ornithine, and ornithine is converted to citrulline and to arginine, and then arginine can be metabolized to ornithine and produce urea, and that is what is called the urea cycle. So what is important is that most of the source of arginine to maintain what is called an amino acid pool, and we're going to talk more about that, comes from our own protein turnover. So it is essential for human beings to maintain adequate amounts of muscle mass. And when patients lose their muscle mass, we call that sarcopenia. Arginine is also produced in the kidney and is exported, but other cell types can also produce it. And our normal dietary intake is 3 to 5 grams per day. And as you will see, we can alter that intake significantly and significantly alter the concentration of arginine in plasma, which is normally 80 to 125 micromolar. So we have a source of arginine with normal dietary intake. We can increase it through arginine replacement therapy. We have a significant amount of protein turnover, which is the main source of arginine, and there's arginine synthesis from glutamine and citrulline in these patients. Now, arginine plays a multitude of physiologic roles. The most important role is that it is a central amino acid to make new protein. So it participates in the anabolism of new protein, and there are exquisite sensors in our body and in our cells to determine whether we have adequate concentrations of arginine so that it can be incorporated in new protein. When cells sense that there's not enough arginine, anabolism will cease. And so there's a significant effect on protein anabolism, and we'll see the importance of that. But arginine plays also important roles in the production of nitric oxide, and I will concentrate a significant amount of my work on how the lack of nitric oxide affects clinical outcomes. And so I will concentrate on both on anabolism and nitric oxide production. One of the things that is important for protein anabolism is that the amino acid pool has to be in a very sensitive concentrations for each amino acid. And there is what we call an ideal amino acid concentration. And when we take protein, the protein that best mimics what we see in our pericellular or extracellular concentrations gives us what is called the biological value of that protein. So the protein that has an optimal concentration has a very high biological value, meaning that that protein is digested and then can be used for anabolism. And so some protein just have some of these amino acids are deficient and they cannot be used for anabolism. When a specific nutrient or a specific amino acid becomes limited, that is, it decreases in the amino acid pool, the anabolic process is limited by the concentration of the lowest amino acid in this pericellular environment. And therefore, when arginine becomes deficient, the anabolism is significantly curtailed, and our cells are forced to actually get rid of other amino acids and destroy them or generate energy instead of generating new protein. And so that is what I am going to show occurs during certain illnesses. And what I will show is that once we understand this metabolism and health, and we see that in certain illnesses, there are definitive mechanisms that lead to an arginine deficiency state. This affects a number of downstream metabolic processes, which create alterations in organ physiology, which are manifested as clinical illness. And we can then evaluate that and determine how arginine replacement therapy is going to overcome these alterations, restore our organ physiology, and then we can, once we demonstrate that there's a clinical benefit by restoration of organ physiology, then we can use arginine replacement therapy as a standard of care in medical practice. And so what we see during illness is that we are forced to dramatically change our metabolism, and that these changes are essential for the survival and repair of the individual. And we see this alteration not only in arginine metabolism, but we see it in other nutrients, such as in iron, for example. There's a profound alteration in protein synthesis during illness. And again, this is important for survival. But this metabolic processes may be pathologic, either because the disease itself requires an alteration in metabolism of different nutrients to favor itself. So certain cancers, for example, can cause nutrient destruction, as I'm going to show, or because the host may have inadequate or exhausted stores of specific nutrients. In those cases, nutrient replacement may be beneficial when it restores and or sustains a physiologic response. Now, if you do not have these deficiencies, the restoration or giving a nutritional supplementation of a specific nutrient may either cause no benefit at all, may cause no harm, but potentially it can cause harm if there's an impaired physiologic response in these patients. And I'm not going to talk too much about that. I will mention it one more time. If you look at a graph, and in theory, look at the increasing concentration of a nutrient outside of the cell as the cell incorporates this nutrient, and look at any function, either physiologic or biochemical, we see that this is a curve. And this was first determined by Michaelis and Menton in 1905. And this is a basic principle in metabolism of any nutrient. And what you see is that there's a dependent portion I'm sorry, that there's an independent portion of this concentration. That is, once you hit saturation levels of the nutrient, once the levels of the nutrient are normal, you do not, giving more nutrient does not produce any biological benefit. In fact, there can be an excess that can cause harm. But then there's an area where you are dependent. The biological function is dependent on the concentration of the nutrient. And in these cases, we call that, or we tend to call that malnutrition, although it's a little bit more complex than that, but we tend to call that malnutrition, or at least of a specific nutrient, and therefore you have an indication to replace that nutrient. In this case, it is arginine. This is a real now graph of what are called CD4s, or T helper lymphocytes. Those are the ones that are central and essential for the defense against parasites, against viruses, certain bacteria, and are the ones that are become abnormal or are depleted during certain illnesses such as trauma or surgery, certain infections such as HIV, and other conditions such as certain cancers. And so if you look at it, there's a beautiful correlation between the concentration of arginine in the culture media, normal, again, being about 80 to 125 micromolar, and the optimal function, in this case, proliferation of T lymphocytes. And therefore, we can see that from the theory of Michaelis and Menton, this is actually clearly something that becomes important and is biologically relevant. And so if the disease is associated with a decrease in arginine, then the question becomes, should we replace it or not? And what we demonstrated across time in the last 25 or so years is that there was a number of diseases such as trauma, and this was a group of trauma patients where we saw a significant decrease in arginine plasma levels. We saw a significant decrease in arginine in certain cancers, such as renal cell carcinoma, with a corresponding increase in ornithine, and that gave us some clues. And we see, and this was produced by Claudia Morris, now at Emory University, that under certain conditions in hemolytic diseases, there is a significant decrease in arginine, and she measured what is called arginine to ornithine ratios, or global availability of arginine as a measure of arginine availability. So how do these diseases, why is arginine decreased in these diseases? And there's a number of mechanisms that I'm going to try to summarize. This graph looks really daunting and complex, but the truth is it's not that difficult. There are non-specific ways on how arginine depletion occurs. And when I say non-specific, is other amino acids are also depleted. And there are two examples: when your diet is poor in protein, and that is quite frequent during illness in humans, and in patients that come otherwise with low muscle mass or sarcopenia. And so all that it takes in this patient population that has non-specific depletion of arginine and other amino acids is to provide adequate nutrition. So basically what you have to do is supplement protein in these patients. But there are specific mechanisms by which arginine is depleted and or becomes deficient. The most important of these mechanisms involves the release or the production of an enzyme called arginase, and which is either present in humans in the red blood cells. Other species don't have that, by the way, or in the liver as part of a urea cycle and released either through ischemia, necrosis, or through hemolytic diseases, or through transfusions, or it is produced in a specialized group of cells that we first described somewhere around 2006, which had been described in certain cancer patients, but nobody understood the mechanism, and which are now called collectively as a family of cells that are now called myeloid-derived suppressor cells. and they're seen in surgery and after trauma, in cancer, and in certain infections. There's another mechanism which I will not talk about, unfortunately, because of time, which is that we accumulate a what is called asymmetric dimethylarginine, which is that the arginine in protein is methylated, and when it is recycled, this substance is concentrated in patients with chronic kidney disease and cardiovascular disease and may cause harm. And so, unfortunately, I won't have time to talk about that. So this is a picture of myeloid vasopressor cells. We were interviewed by Jean Marks in 2008, and this appeared in the journal Science, as the people that really had been working on these weird cells that now were found to be central to certain illnesses, particularly with an emphasis on cancer. But we had really focused on trauma and injury because of my background. Now, what do these cells affect? These cells either stick to the T lymphocyte and rob the arginine, or the arginase contained in these cells is released, or arginase is released from hepatocytes or erythrocytes, and they deplete arginine. And so obviously, we look at T lymphocytes and we look at protein translation in T lymphocytes. And therefore, we can measure things such as proliferation and cytotoxicity and memory and cytokine production and see how these are negatively affected and how they affect outcome. We look at nitric oxide, which is a very potent vasodilator and therefore increases oxygenation to tissues. And therefore, we can measure tissue oxygenation in the presence of abnormalities in tissue oxygenation, which we call ischemia or necrosis as a more advanced, and again, look at outcomes. And we're going to look into that. There are other roles which I will not be talking about today. And so let's look into this at this point. And so arginine replacement therapy, in theory, should benefit any patient that has arginase as a systemic release, either from hemolysis or from hepatic necrosis. And that becomes important. And I can tell you now, and a little bit of a spoiler alert, it is now a level 1 indication to replace arginine in sickle cell disease, for example. Now, in patients that have an increase in myeloid vasopressor cells, and I just found a couple of weeks ago that there's now over 7,000 articles on this, there is more of a theoretical distribution of when you should be replacing arginine. We know now, and I will show you the data on elective surgery, particularly for gastrointestinal cancer, and I will show you the data on head and neck cancer, both in surgery and as part of what we call adjuvant therapy, which is chemotherapy and radiotherapy. There is research done in other surgeries and in trauma and in certain infections. And then, interestingly, there are certain conditions wherein actually giving arginine could be dangerous. And so we call that a contraindication to give arginine replacement therapy. And in fact, some investigators are working on what is called arginine depletion therapy. And I will unfortunately not talk about these, but some hematologic cancers and maybe some liver cancers may potentially benefit from arginine depletion therapy, although that is far from becoming a standard of care. And so despite this confusion, I really will want to focus where this arginine replacement therapy becomes important and central to us. Now, we can alter arginine concentrations by oral intake and through oral or dietary intake or IV intake. And that becomes important. When we use a nutrient supplementation as part of therapy, we need to treat that nutrient as if it were a pharmacologic agent. Although, as you can see, we're not talking pharmacology, we're just talking a nutrient deficiency. But we need to have very strict guidelines of how are we going to measure how much we're going to give, for how long, and at what concentration. And so we did quite a bit of work on looking at oral nutritional supplements, changing the concentration of other macronutrients such as calories, and demonstrating that when we gave 4 grams in one dose, we could significantly increase arginine plasma levels and therefore pericellular concentrations for up to 6 hours. And that becomes really important because then we can start thinking about a dose that we need for patients. And we're going to be talking about that. When every patient, and this graph is a little bit weird in the sense that the higher the number, the lower the lymphocyte function. And so normal lymphocyte function would be here, or here, and very pathologic lymphocyte function would be here. And what you see in this very carefully done study, in which patients undergoing gastrointestinal surgery for colon cancer were given 12.5 grams of arginine per day for 5 to 7 days prior to surgery or prior to and after surgery. So one group received arginine prior to surgery, one group received arginine prior to and after surgery. One group received what is called an isonitrogenous isocaloric diet, that is, same amount of protein, but not arginine supplementation, same amount of calories. And then one group received nothing, saying, well, the standard of care is to do nothing particularly if you're well nourished. And what they demonstrated in this study, and we'll see the clinical results afterwards, is that T lymphocyte function was clearly better preserved if you give arginine preoperatively or prior to and after surgery, perioperatively, compared to either the control group that received the same amount of calories and nitrogen or nothing at all. And what you can see is that giving more food, that is, treating, quote, malnutrition as if it were just a problem of more food, does not work, does not restore T lymphocyte function. Now, let's talk about vasodilation. So in 1987 to 89, after 3 different kind of veins of research coalesced, we demonstrated that in our body, we are able to make nitric oxide, which is a potent vasodilator, and that we have different enzymes called nitric oxide synthesis. And that became a huge area of research. And there's many medications that now use this pathway, including nitroglycerin and nitrates and nitroprusside and the famous Viagra. And so what we demonstrated in humans in 1991 was clearly that when you became septic, your levels of nitric oxide, circulating nitric oxide, and the end product of nitric oxide is nitrates in the blood, increased significantly in humans, and that was associated with increased vasodilation and hypotension of sepsis. And so your blood pressure dropped when you were sick with sepsis because you were making too much nitric oxide. Interestingly, trauma patients, if you had an injury first, you did not make nitric oxide. In fact, if you became septic after a trauma, you were still incapable of making nitric oxide. And remember, in these patients, we also demonstrated that there was a decrease in arginine availability. And similar observations were demonstrated by different investigators, again, including Dr. Claudia Morris, showing that the number of adverse cardiovascular events in patients with sickle cell disease increase significantly as your arginine levels are decreased across time. In fact, low arginine levels are a very sensitive marker in patients with sickle cell disease that you're going to do quite poorly. So what do we have so far? We have that low arginine affects T lymphocyte function. It worsens clinical outcomes. I'm going to show that it worsens infections. it worsens tissue oxygenation. It is not normal to have an infection after surgery. You should not have that. It is not normal that your skin and your wounds necrosis and develops ischemia. And people accept that, oh, that just happened, but we can potentially prevent. So how can we restore arginine in our patients? And I mentioned a little bit of that, but I want you to all understand that humans are not models, and that no matter how much in vitro modeling or how much we do of trying to understand, human beings are messy. And so arginine deficiency develops by different mechanisms in our patients. We said poor diet, which is unfortunately quite frequent, particularly as you age. We mentioned that sarcopenia and increased concentrations of asymmetric dimethylarginine, as we see in chronic diseases. Then we see that certain cancers increase the presence of myeloid-derived suppressor cells, and those tumors use those myeloid-derived suppressor cells to block T lymphocyte function. And patients that are undergoing surgery for cancer now get a second hit, and that surgery induces those myeloid-derived suppressor cells and depletes arginine. And then in many patients, we see hemolysis and we need transfusions and we see ischemia. So patients do have a number of different mechanisms of how they develop arginine deficiency. Now, we could restore arginine through different concentrations of what we give in the diet. And the best work was done by Robert Evans. And my apologies that I don't see the reference here, but it was done by Robert Evans, and you can look for it. And he gave different concentrations of arginine and demonstrated that somewhere between 9 and 21 grams per day, you could significantly increase arginine in the plasma. And therefore, we use that dose approximately in our patients. But arginine is not given alone. You have to eat. And one of the things that is important is that we need to give some additional protein when we give arginine replacement therapy. And the other important thing is that we need to restore fatty acid physiology. And I will show the graph of the FACS trial, but what we know right now, at least in the United States, from the best data available, and there's huge gaps still in our understanding, is that up to almost 90% of the population of people that are otherwise healthy, greater than 50, and are older than 50, have a severe omega-3 fatty acid deficiency. And that, again, there's still gaps of research that need to be addressed in this. These diets have become, this arginine supplementation has become a clinical set of commercial products by different organizations. And people call this as immunonutrition or immune-enhancing diets or immune-modulating diets or all. All of those things are, and all of those names are very inexact and misleading in many cases. And so I use the word arginine replacement therapy as a more pure way of saying this. Having said that, you will see these terms in the literature quite a bit. And this is the FACS trial. And again, when you look at patients, most of these people that were otherwise healthy, the concentrations of omega-3s in the plasma is very, very low. So the protocols have evolved to give us this idea that we give arginine 5 to 7 days preoperatively and about 5 to 7 days or 10 days postoperatively. It is important that arginine replacement therapy be done in pulses and generally no more than 10 or 15 days. And that becomes really important. Giving arginine for the long term, and unfortunately, some people use it empirically, has not shown any benefit, and in fact, has shown harm in different patient populations. Interestingly, arginine is not just kept in the plasma, it is actually concentrated inside the cell. In this case, Roger Geiger and Antonio Lanzavecchia demonstrated that arginine is concentrated inside the T lymphocytes. And therefore, when the patient comes to surgery, if we are able to give arginine prior to surgery, we can replete arginine levels inside the cell and better prepare that cell for improved survival after the surgical insult. So in humans, we have shown, and it has been shown, that 12.5 grams per day does increase arginine plasma levels compared to controls, and that becomes important. So we can restore arginine through dietary interventions. And if you look at it, and this is a prospective randomized control trial in colon cancer, we see that, and this was in malnourished patients, we see that given arginine prior to surgery does improve outcomes by reducing the risk of infections. But if you give it prior to and after surgery, you get an added benefit. What about well-nourished patients? The answer is you get the same benefit, although it is more striking that you have to give it prior to surgery, or you should give it prior to surgery, that there is a modest improvement if you give it after surgery. But what is important is that arginine replacement therapy in surgical patients is not for treating malnutrition. It is for treating arginine replacement therapy, and therefore it should be given to every patient that is a potential patient that has arginine deficiency, in this case, any patient with GI surgery. Same thing happens to patients that have gastrectomies. And then you see that improved tissue oxygenation in these patients leads to better wound healing and to a lower incidence of breakdown of what is called the anastomosis, where you hook up the gastrointestinal tract together. You see that another group of gastrectomy patients undergoing gastrectomies for cancer. And after many years, a group under John Drover, Rupinder Dhaliwal, Darren Hyland, Paul Wishmeyer, and myself did a meta-analysis and demonstrated that no matter where in the gastrointestinal tract, if you're receiving arginine replacement therapy, you get about a 30 to 50% decrease in the risk of post-op infections. And interestingly, if you give it prior to and after surgery, you get a statistically significant improvement in outcome compared to if you give it prior to surgery, where you see a benefit, but it's lower than if you give it prior to and after, or you give it after surgery, where also you see a benefit, but again, it's lower than when you see it give it prior to and after surgery. That has led to different organizations to advocate as a state-of-the-art, as a standard of care, the use of what is called, again, immunonutrition. Some people say give it preoperatively, other people say give it perioperatively. Important, from my point of view, what is important is that there is a clear benefit in patients with surgery for gastrointestinal cancer to receive arginine replacement therapy, and that this should be standard of care. And we all need to work to make this a standard of care. This is the European societies saying this. This is the American College of Surgeons saying that immunonutrition is strong, which is the strongest evidence that they can give us and the strongest recommendation for gastrointestinal cancer. This is a meta-analysis in Asia demonstrating the same benefit, including this wound healing, and advocating for this. Now, some people say, well, that's nice and clear in very controlled studies. What happens in the real world? Our doctor is going to prescribe this, our patient's going to take this. And so we worked on this, and full disclosure, at that point I was the chief medical officer for Nestle Health Science, and I funded the study. I did not participate because of ethical considerations on the statistical analysis of this. I participated in the design and how this paper was written. But what was obvious in this is that, yes, there were lower infection rates in the real world. We knew that. There was a very significant decrease in venous thromboembolism because of better vasodilation. But the most striking benefit that we saw, which we had not seen before, was this dramatic decrease, almost 50% decrease in the risk for readmission rates in the first 6 months after surgery. This is a huge deal. And so we are now seeing a benefit, and there was a significant decrease in cost, obviously. So there's now a public health, evidence of public health benefit with this. So my conclusions is that there's no controversy at this point in arginine replacement therapy after surgery for gastrointestinal cancer. It is time to adopt that. And if there's a message that I want to leave everybody is, it is time to change the culture and to say, okay, this has a benefit. Now, are there more promises and benefits? And you see that arginine depletion by myeloid-derived suppressor cells is now seen as a real problem in many different cancers, including breast cancer and in other gastric cancers and in other types of cancers. And therefore, it is an area of really important research. One of the areas is head and neck cancer. Now, head and neck cancer is a really very tough type of tumor. Normally, most of the patients have one type of what are called one cell type, which is a squamous cell type of carcinoma. And surgeries can be very devastating and very tough. And one of the problems that happens in these surgeries when you have to remove part of the larynx or do types of surgeries is that you can develop ischemia, lack of blood flow to the skin and the muscles when you're removing all of this, and that almost 18 to almost 20% of these patients can develop lack of wound healing from that, and therefore they develop what is called a fistula, where the saliva comes through your wound, and that is a devastating complication. Daniel DeLuise demonstrated that if you give arginine at optimal levels, you can decrease these complication rates quite significantly. In fact, almost sixfold. There's very few therapies that are so wonderful. There are now more than half a dozen trials that demonstrate this. It's still not considered standard of care, but I want people to realize that there's a clear promise. And so far, there's not been any evidence of harm with this therapy in this patient population. Adoption of arginine replacement therapy in this group of patients as a quality improvement, now not in prospective randomized trials, but in the real world, in what are called real world studies, now looking at public health, demonstrates again a consistent improvement in clinical outcome in these patients. And interestingly, there's an anecdotal observation that if you receive arginine replacement therapy around the time of surgery, at 10 to 12 years, you see the group that received arginine replacement therapy continue to survive at significant levels compared to the control group that just received a regular diet. And it only took 15 days or so of arginine replacement therapy. This anecdotal observation is reinforced by the group of Pierre Senes and others in Marseille, where a prospective phase 3 trial following a phase 2 trial, so a highly well-developed clinical trials, which would be considered the golden standard of research, where patients with head and neck cancer undergoing radiotherapy and chemotherapy received different cycles, and then they received 3 cycles. Remember that I said arginine replacement has to be given in cycles. This becomes really important, is that you have to give it in cycles, and these patients received 3 cycles, and what you demonstrate in this graph is that at 48 months, there is a significant improvement in tumor-free survival in this patient population. This is a level 1 evidence. Ideally, we should get a second study that demonstrates this, but from the point of view of a clinician, this holds a very significant amount of promise and consideration, and serious consideration. So what I have demonstrated is that there's something called arginine deficiency syndrome, and I hope I have convinced you for this. It generally starts prior to surgery in human beings. It is worsened by the surgical insult. It negatively affects T cell function and tissue oxygenation. So it is not normal to have abnormal T cell function and poor tissue oxygenation after surgery. We should not accept that as fate. We can treat it, that in implementing arginine replacement therapy in patients with elective surgery for gastrointestinal cancer should now be considered a standard of care. It is clearly, from my point of view, clearly easier and clearly better to give it prior to or after surgery, although there's some discussions about that in the literature, which I personally think are Byzantine. We should just give it and stop trying to make this so complex that people don't receive the therapy. There is also level 1 evidence in hemolytic diseases, such as sickle cell disease, and I didn't show that data for lack of time, and that there is a promise for different patient populations. Head and neck cancer is quite close, and that there's multiple opportunities for research. I want to thank you all for the opportunity to give this presentation. Again, I apologize for not being there due to health reasons. Thank you so very much.